Hey, I'm Jim Wiedrick. Every day I'm working to transform healthcare in Southeast BC, and one of my big ideas was having one-on-one conversations with smart people, people who are involved in patient care in our region, and that have hands-on knowledge of what we need to help make things better for us to optimize the patient interactions, results, and outcomes that everybody in this region deserves and needs. Today I'm really pleased to be joined by a family practitioner oncologist who works in more than one community in our region, Jeanette Boyd. Thanks for coming on our podcast, Jeanette. How are you today?
I am very well, Jim. Thank you for having me.
Hey, I think that a lot of people who aren't involved in the system are aware that there is, some high strain on the cancer care system in BC right now. At least that's sort of the public perception. So I wonder if you can just give us an overview of how things are working and flowing in cancer care in our neck of the woods these days, and what if, perish the thought you had to be engaged in it, it would kind of feel like. Give us the big overview if you could.
Yeah. So like any sort of diagnosis where even the possibility is, could it be cancer, is going to be incredibly stressful. So there's several areas where people will encounter some bottlenecks, if you will, where it's going to be hard to enter the system. So in initial diagnosis, what exactly is going on? So waiting for imaging and then maybe waiting for a biopsy. And all of that is being done usually by their primary care provider if they are fortunate enough to have one. Or otherwise, sometimes they'll be presenting to the emergency department being quite unwell. And then at that point, once they have a formal diagnosis of cancer, the next step of waiting is to see a medical oncologist or a surgeon, which is, again, another place where there may be some what feels like forever for these people with the uncertainty. But then at that point, once they're into the cancer system and formally within the confines and the care of BC Cancer, things tend to be a lot more streamlined, even though there still is that sense of uncertainty until you formally meet with one of the medical oncologists, for example. So in the Kootenays, our medical oncologists, who are the specialists in cancer care, they've done, the ongoing specialist training for 5 years, 7 years past medical school. They're all based either in Kelowna or Vancouver. And they are the medical oncologists are the ones who will be the primary, what we call most responsible physicians. So they will guide you through recommendations for treatment, everything from chemotherapy to immunotherapy, all the way through targeted therapies. And then we're fortunate enough to have a very collaborative approach to providing chemotherapy and systemic therapy in areas beyond Kelowna. And so to allowing you to receive that very important cancer care therapy closer to home. So that would be in areas like in Nelson and Trail, in Cranbrook and others, where there's family physician oncologists like myself, who are family doctors who have our generalist training in family practice, but then have done additional training in oncology. So we're basically the eyes and ears on the ground and the primary implementers of the care plan that is given by the medical oncologists up in Kelowna. And we have this amazing and incredible team of care providers, nurses. It truly is a collaborative approach with nurses, pharmacists, social workers, and well connected with the groups in Kelowna and in Vancouver. So once you're in the system, it's quite good in general, but getting into the system, there's a lot of uncertainty and stress and anxiety associated with that.
So if I understood correctly, then there's this bit of a period where you've got to get that contact with the high-level specialist, whether that's the medical oncologist or whether that's the surgeon. And then after that, a lot of the care is provided by folks like you, who then work in collaboration with these folks at the tertiary care centers.
Correct, yes.
And What is a typical, and I know there's so many different kinds of cancer, but what is a typical kind of duration of time that people spend in the system? Like, could you say, well, many people are there for 3 months, or is it always 6 months, a year? Like, what do you often see, or what's the spectrum of that kind of
Yeah, and again, you're quite right. It is a spectrum, and it depends on the kind of cancer, where they are in their cancer diagnosis, what stage of cancer there is. But in general, if it is a type of cancer that involves systemic therapy, so chemotherapy, anything that goes in through an IV or oral pills, if we're looking at treatment and treatment to cure, often you'll be within active treatment for anywhere from 6 months to 2 years. After that, you're never really out of the system. We work very closely with your family doctor. We do very close follow-up at, for example, in the Nelson Clinic, where after you've done your initial treatment, we will be seeing you every 3 to 6 months for the first few years to make sure there isn't any recurrence of your cancer, to make sure there aren't any delayed side effects of your treatment. And we'll be seeing you on a regular basis for at least 5 years. We would like to see patients in conjunction with their family doctor. We really believe having the family physician staying involved with their patients' care, seeing them on a regular basis. We do our best to have really clear and concise follow-up plans with their family doctors, so we work collaboratively. So you're never really out of the system. We're always there if needed, but typically if we're looking for cure, treating for cure, a minimum of 5 years being in the system for follow-up, and typically anywhere from 6 months to 2 years for active treatment. For some people who unfortunately do have later stage cancer, the care is continuous. We're with you all the way through. Sometimes you'll go into a period of surveillance, but we're the ones who will be doing the surveillance, again, hand in hand with our team in Kelowna and with the patient's family physicians or nurse practitioner.
Right on. Thank you for that overview. So would you say that the percentage of the population that has been diagnosed with cancer is on the rise? I mean, I think that is something that people have a gestalt about, that more and more people are getting cancer, but do the statistics bear that out, or what's on the ground in terms of the volume of folks that you have to help process through the system now?
Yes, there certainly are more people being diagnosed with cancer. Part of that is just that we have an aging population for certain, and that is a good thing to have. People are living longer. There's more people, the baby boomer generation that is moving into where we'll see more chronic disease, where we will see them developing cancers as they get older. So that is going to be certainly increasing the volume, the number of people that we're seeing. Another problem, which is an excellent problem to have, is people are living longer with cancer. We have amazing and phenomenal treatments now over the last 10 to 20 years, new forms of treatment that were people who had previously maybe only lived for 1 or 2 years after that diagnosis are living for 10, 15 years beyond that, and they are still in the system. As I said, some of them will continue on treatment for years and years, or at least in surveillance. So that's an additional pressure on the system, but a good problem to have, for sure.
So are there enough providers? Like, I have definitely heard that we do not have enough medical oncologists, but what about folks like you?
Yes, it's we're very fortunate in Nelson that we are we have an excellent team of physicians who are able to cover each other. So we do have enough coverage in Nelson, but that's the rarity. Most of the what we call community sites for distributed cancer care are understaffed, not only in terms of nursing, but certainly with family physician oncologists who, are without a family physician oncologist on site, any site is not able to administer chemotherapy. So it is certainly a struggle, and anticipated as cancer care becomes more involved and more people in higher volumes, it's going to be an even greater stressor on the system. medical oncologists, as you said, they are definitely in short supply, and also are, very much stretched thin. It's a very delicate balance that we have right now in terms of accessing care within the recommended treatment guidelines. And then radiation oncology is another thing that we haven't touched on, where it is a very finite time and equipment limited space. So as more people are coming into the system, the demands on those structural aspects, like the radiation treatment suites, there just isn't enough of them to allow us to provide treatment in as timely a manner as people would like.
And in this region, in sort of the east and west Kootenays, is everyone flowing towards Kelowna for any kind of radiation therapy?
Yes. Yeah.
At one point, there was a discussion about having a radiation facility in Cranbrook, but is that in the distant future, or what can you give us as a summary for where that might stand?
Yeah. My understanding is that it is not being included as part of their new cancer center that is being that has been approved for Cranbrook. It isn't part of their design right now that I'm aware of, so it'll be in the distant future probably.
And basically then that just means that folks who need that have to be prepared to make the trip and then find accommodation or a place to stay in Kelowna so that they can complete that intensive kind of burst of treatment that they need.
Yeah, and fortunately there are some resources available. The Canadian Cancer Society now has a travel fund available. The Ministry of Health also has some funding available. It isn't sufficient to cover all expenses and costs. But it is certainly for those people who don't, who are below a certain threshold for income, all of their accommodation and meals are covered. There's a fabulous, through the Rotary Club, they have a fabulous sort of clubhouse that allows for accommodation for people who are in Kelowna for extended time for accessing their treatment. And the social workers that are a part of our team, if you're fortunate enough to have a social worker in your team, that they're also in short supply. They're often really helpful in terms of coordinating all of that, the logistics around accessing treatment further away. But it doesn't, as I've said, it doesn't cover all of the costs that are associated with that. It's a long way to travel, particularly in the winter. Sometimes you're going to be there for up to 5 weeks. Sometimes it's just over the pass to get there for 1 or 2 days of treatment. But you need to have somebody drive you. You don't want to be going through something as stressful as a cancer diagnosis, as radiation treatment, being there on your own. So that puts a lot of stress on families and friends, and time away from work and all of those sorts of things. So it is a very complex cost that I don't feel, those who are in rural areas take a higher burden on their mental health, financial stability compared to their compatriots who live in more urban areas, who do have much closer access to cancer care.
Yeah, and when you're talking about traveling for treatment, regular listeners of this podcast will be aware that I've been definitely a fierce advocate for more access to CT scanners or some of the imaging opportunities that we have. And we only have a couple of places in our neck of the woods that can do that. Mm-hmm. But when I did a top 10 list of things that CT is used for, all of the CT techs I talked to said that, cancer diagnoses were at the top of the utilization for how we use CT. How does CT and all of the imaging fit into the kind of work that you do? Is that more front-loaded, or is there ongoing kind of protocols where you need to order or use it more in the kind of work that you're doing?
Yes, so certainly front-loaded, but constantly throughout the course of most people's cancer care. If they have solid tumors, for example, so breast cancer, colon cancer, all of those sorts of things, and even things like lymphoma, we need to do regular surveillance, and that requires a CT scanner. We're looking for recurrence, we're looking for complications, we're surveilling for how good our treatment is working. Is it working? Do we need to make changes? So for some people, when they're going through their treatment and when they're being closely monitored after they've gone through their treatment, we could be doing scans up to every 3 months, which is a huge significant impact on the system, but a necessary impact. And, trying to get that balance between these people who need this surveillance testing done and those who need more acute access, it's a very, I'm sure it's an incredible challenge for our radiology colleagues to try to find that balance and ensure adequate access and timely access for everyone.
Yeah, thanks. So when you take, a pause and a thought and you say, what would be the most valuable additions to our system, to our cancer system, if you could run the world and have your magic lamp grant you some wishes, what would be the top couple of things that came to your mind for things that we could use or we need to help make cancer care in our region even better?
More people. It's the human resources aspect. As we had mentioned earlier, the family physician oncologists, nurses, pharmacists, they're all in short supply. And then the allied health, social work, counselors, they're, grief counselors, palliative care, it's all part of that continuum, which is so critical. Family physicians who are going to be involved in screening and taking over that follow-up care. We really do need more people. That is the most critical aspect, that whole team-based care to be wrapped around. And then there's the more practical, logistical, bricks and mortar aspects about enough space to do treatment, enough time to do treatment. All of the cancer clinics that I'm aware of just don't have the adequate space to maintain and accommodate all of the patients that they have. They're being squished into these tiny areas. So additional focus on resources and spaces is important for sure.
Is ultimately that a Ministry of Health in Victoria level of initiative or decision making? Or I guess really the nature of my question is there something that folks in the medical field at a much more local level could do to impact that beyond advocating and public relations kind of requests? Is it ultimately Victoria that needs to be the distributor and organizer of all that, or can you see other ways in the system where there might be good things brought to bear?
Both, I would say. Certainly, the major funding is going to be coming from the Ministry of Health. And as we know right now, with the budgetary constraints, the uncertainty with the tariffs, we don't know what that funding envelope is going to look at or look like. So, they just certainly are the ones who are responsible for the larger human resources, for the larger aspects in terms of access to treatment protocols, equipment, all of those sorts of things. From a more local perspective and what others can do in terms of advocacy, things like really lobbying for team-based care, creating opportunities for recruitment and retention. Communities have a lot of responsibility or can contribute a lot to those areas to bring providers into the communities. Another area that I think is really important is both on the prevention side. We know that there is so much that can be done in terms of prevention, but there's also so much information that's out there around prevention and treatment and such. So I think a lot of us, certainly in medicine, have a social responsibility to be doing more in terms of prevention and lobbying and advocating for those aspects for sure. And then advocating for team-based care, I think, is another really important aspect. Family caregivers is another area where I see us really having we don't do a good enough job, and they are so critically important in terms of supporting their loved ones through their whole cancer journey, all the way from diagnosis all the way through to active treatment, that it can be very challenging for them. And I think we need to do a better job of supporting them as well. It really is, so many people are involved and it impacts so many, that we need to do a better job at supporting them.
People in the patient's circle of influence who are truly influenced or have a true need. I think those people get forgotten about. Yeah,
Absolutely.
Well, hey, I love that you brought up prevention, because as I was, talking about this, I realized that a lot of the questions I'm asking are focused on treatment. And here's two things that over the course of my adult life I've come to understand would make a huge difference in the cancer burden. Well, eliminating tobacco from people's lives. Okay, I think we're all on board with that matters, and that's different. And then the other thing that during the course of my career has really cropped up and has been a revelation is how, as we vaccinate against HPV virus, we can basically prevent cervical cancer if we had broad enough uptake of that. So I'm going to say, okay, I got to name those two easy ones. Now hit me with another 3 or however many you like, preventative things that if people, the population wide, would maybe buy into, that we could lower the burden of cancer in our society.
Yeah. There's 4 that I can think of
great.
right off the bat. Sunscreen, avoiding the sun, not being out between 10 and 2, and if you are, wearing long sleeves, keeping your children out of the sun, wearing hats. That one's so simple and easy to do, and significant impact on melanoma in particular. So that's a quick and easy one. Alcohol is becoming a much, much greater risk factor for cancers, particularly as the tobacco is decreasing. Vaping, we don't know what sort of impact that's going to have on cancer rates. We all thought electronic cigarettes might help people stop smoking, but it has its own risks as well. And sorry, to go back, alcohol is a really significant one. There's been, some lobbying to actually have the cancer warnings like they have on tobacco products put onto alcohol products. So it is a huge and significant risk factor, which is a more challenging one to address, because it still is very much considered just a normal part of our society and socialization. But that it is, I think, trending to be in a much better way. The third one is processed foods. Going back to whole foods, trying to avoid processed foods. There is this trend for younger people to be diagnosed with cancers, colon cancer in particular, and the exact underlying reason isn't really understood, but the increase in processed foods over the last 30-40 years for this whole generation likely is a strong contributor, and we do know things like smoked foods and processed foods are a risk factor for cancer. So trying to have a healthier diet, or at least processed foods in moderation. And then I can go into a whole conversation about access to healthy food choices and income and the poverty level, but that's probably for a different expert to talk about.
Well, you may be an expert, but it's about social determinants of health, isn't
Absolutely.
it? There,
Yeah.
Yeah, I think we sometimes neglect conversations about that because it seems like it should be being figured out, but it's often not being figured out.
No, if it was easy, it would be done already, but it is. The social determinants of health are such a huge and amazing and critical factor in so many aspects of health and wellness, and that kind of leads into my number 4, and it is around social determinants of health. It's stress reduction. How can you lead a healthy lifestyle? How can you minimize the amount of stress that you're being exposed to? We really don't have any quantitative ways to say, yes, it's contributing to cancer, but we know things like adverse childhood events and people who are in a lower socioeconomic status, don't have the same levels of education, do have higher rates of cancer. So that is another huge envelope that needs to be addressed.
The last category that I wanted to make sure I asked you about was your current assessment of how we're doing as a medical system for screening. So, like, there's multiple different categories of screening we could talk about. We could talk about breast cancer screening or prostate cancer screening or lung cancer screening, and you can take this in any direction you want. But just generally, do you think that we're in a good or a sweet spot with how we're keeping society screened? Or have we lost the plot a little bit and things aren't as slick as they should be?
Things aren't as slick as they should be. Certainly the primary care crisis, people not being able to access family physicians or nurse practitioners, any sort of primary care provider. For a period of time, you could only get cervical cancer screening if you had a family doctor or if you had a primary care provider or kind of was going through a sexual health clinic. Similarly, for mammograms, you needed to have a family doctor to have your mammogram results given to. So it is starting to improve. Now you can self-refer for breast cancer screening. You can self-refer for pap smear for cervical cancer screening, and now you could do your own cervical cancer screening. You don't even need to go and have a pap done, which is fabulous in terms of access. It's wonderful. But other things like screening for colon cancer, screening for lung cancer, it is a little bit harder to access the system. We don't do preventative health exams anymore in primary care. And that was when you had these opportunities to discuss risk factors. You had these opportunities to spend time with the patient talking about skin protection and giving them a really good conversation, informed choice conversation around breast cancer screening, around prostate cancer screening. And we just really haven't had the opportunities to do that the way we should have. COVID was another area where all of those preventative things were kind of deferred and delayed for 2, 3, even 4 years sometime, and we're still having this backlog. So it certainly has been challenging. I think we can do more in terms of advocacy, in terms of getting the information out there. I think Gen Z or Gen Z really has, using social media to reach out and access. So I think we need to do a much better job. You alluded to the vaccinations for the HPV and what impact that has. And I think education around vaccines is also going to be a really important area to go into as that population gets older as well. So lots to be done. The Kootenay Boundary Screening Clinic has been a phenomenal way to address that lack of access to screening opportunities, and it was really gratifying to see that clinic come into being.
Cool, very cool. Yeah, I'm fascinated. I've had a couple of conversations with patients in the last 5 years with, the journey of information that's out there over the last 30 years, because I can remember writing everything I was learning down in the 1990s. I didn't have anything else to collate it with. And now we're at the place where we have basically almost all of the world's information at our fingertips and our phone. And yet we've flipped the script a little bit, and now we're having to fight misinformation in ways that I never imagined 10 years ago. And I guess that's more a comment than a question. If you have something amazing to say there, please teach us all how we can overcome some of these barriers. I worry. I want people to have real, true info and not be steered in troublesome directions.
Yeah. The information is overwhelming, and as you know, Jim, the amount of medical information, I think the stat is it doubles every few months or so. So to stay on top of everything, it's really challenging. And patients, I'm very glad they feel empowered to learn more about their own cancers, to learn more about their own treatment. But how can we guide them to have those reliable resources and those reliable sources? And there's some really known good ones. The BC Cancer Society, the Canadian Cancer Society, the Mayo Clinic, the Cleveland Clinic. Those are the main ones that always pop up first in your algorithms when you're doing your Google search. But there are more areas of that have misinformation. So I think we need to empower people to explore to the extent that they want to, make sure they're making informed choices, but make sure the information that they're accessing is reliable. And I think we can do a lot in terms of listening, hearing their concerns, encouraging them to seek out objective information and teach them what does that look like. And that is another area, I think, in medical training and access and in health and wellness and in prevention that really would make a difference and really should be part of our teaching for patient education.
Perfect. Well, hey, Jeanette, I can't thank you enough for helping me cover a big, wide topic and informing people about what the actual realities are and where we're at and the challenges that we're working to overcome. Hey, I am grateful for the fact that you are serving communities across our region for that, and I look forward to having advanced access for everybody, and so that we don't all have to travel quite as much.
Absolutely. Yeah. Thank you.
Hey, cheers, Jeanette. Thanks for what you do.
Thank you.